Welcome back, everyone, and we are at page 377. Let's just jump into it. Master of the Boards, step 3, and we are starting with the immunizations at the bottom of the page. Last time we did the behavioral disorders along with other stuff, and we're starting with immunizations now. At the bottom of the page, we see exam tips, which are important here. We have two tips. The first one, it says premature infants or low birth weight babies. Either way, they do not need to delay immunizations for. So you should not delay immunization for a premature infant or low birth weight. We immunize at chronological age. So we use the same schedule as anyone else, but just chronologically as the spaces between each immunization. And the second one that had to do with premature infants is do not dose adjust immunizations. So just give the the appropriate dose as you would um, with the other any other child or any other infant. The second tip here, it says do not give live vaccines to immunocompromised patients. Of course, that is a given. All right. We have more tips here on the next page. It says that the followings are not contraindications to immunization. And I believe they had that they have 3 points here. And those are the most commonly mistaken contraindications, I believe. So I believe it also could be an ingrowing list. You can add your own if you think at one point that an immunization is contraindicated for one reason or another. You can add it to this list. It will help later on. Okay, so the first is a reaction to a previous DPT of temperature less than 105 Fahrenheit, along with redness, soreness, and swelling. So if we have a reaction to the DPT, diphtheria, pertussis, and tetanus that had temperature but not higher than 105, then we should be fine. If it is more than that, then we have a contraindication here. Okay, the second one is a mild acute illness and otherwise a well child. So if we have a well child, took an immunization, and he got a mild acute illness, we shouldn't really have a contraindication here. If somebody, I'm sorry, I meant that if he a well and otherwise well child, but he just has an acute illness and it's mild, we shouldn't really withhold the immunization here. We should give it to him or her, nonetheless. The third one had to do with a family history of seizures or sudden infant death syndrome. This is not a contraindication. So three things again: the reaction to previous DPT of temperature less than 105, redness, soreness, and swelling. This is not a contraindication. We should give vaccination or immunization, I'm sorry. A mild acute illness in an otherwise well child. Still, we would give an immunization. A family history of seizures or sudden infant death syndrome. We still do give immunizations. All right, now how about MMR here? Well, when I have a patient of documented allergy to eggs, we sometimes do not give MMR, but this is not really true. This is not a contraindication as well. So a documented egg allergy is not a contraindication for MMR vaccine. The other way around here is with the yellow fever vaccine. The yellow fever vaccine, egg allergy does contraindicate. So if you know a child who has a documented egg allergy, he shouldn't take the yellow fever vaccine, but he can take the MMR. Okay, how about influenza vaccine if he has egg allergies? Well, if he has egg allergies, it's not really no longer contraindication to take influenza vaccine. Patients who are more than or at least 6 months with a known egg allergy, they should receive the trivalent inactivated influenza vaccine, TIV. Again, anyone or any patient who is more or at least 6 months with a known egg allergy, he should receive or she should receive the trivalent inactivated influenza vaccine. This is going to be followed by a 30-minute observation period in a facility prepared to recognize and treat anaphylaxis. And a patient with a history of severe anaphylaxis to eggs should be referred to an allergy specialist to receive TIV, or the trivalent inactivated influenza vaccine. Okay. Three more tips here. It says that MMR does not cause autism. Well, no vaccine causes autism. This has been concluded, and we should all know that. And it doesn't also cause inflammatory bowel disease. Hepatitis B vaccine does not cause demyelinating neurologic disorders. And finally, the meningococcal vaccine is not related to development of Guillain-Barré. Okay, so those, if you didn't really know those as common errors or something like that, so you should be fine. You don't really have to read those again to confuse yourself, because sometimes when we read those, we would remember the wrong thing, and then our brain would get activated when we see those as a distraction in the exam and choose it. So just forget it. I would say forget it. If you did not know that those are correct, or you just didn't really think of those, forget them. Would be a lot better. Okay, so we have a table here. It's a pretty large table here, and it has the recommended immunization schedule for a person aged 0 to 18 years in the United States in 2014. It had to do with the CDC. I have a really bad book here. I can't really see well. So I'm gonna leave this one, but I highly recommend that you would print it if you do have a bad version like me, and make it a little bit bigger, because I can't really see those things. And maybe hang it on your wall. I'm gonna hang it on my board, the USMLE board that I did, and yeah, I think this. I'm gonna skip this part, and we can take a look back at it, or make a separate video for it if you guys want. You can tell me in the comments below if you would like that or not. Okay, so I'm gonna skip that part, and we're gonna talk about the two tables that we do have here in the rest of the immunization section. Immunizations after exposure. Okay, so if you've been exposed to this specific disease, I'm gonna mention later on what you're going to do here. Okay. And of course, if you are an infant, let's say the first one is measles here. Okay, if been in exposure for measles, if the infant is 0 to 6 months, we give the immunoglobulin. If 6 to 12 months, we give immunoglobulin plus the vaccine. If more than 12 months, vaccine only within 72 hours of exposure. If there is a pregnant or immunocompromised patient, we give immunoglobulin only. Okay, so we have cases here that has immunoglobulin only, vaccine only, and immunoglobulin plus vaccine. Okay, so let's get rid of the immunoglobulin plus vaccine. Immunoglobulin plus vaccine, that's going to be 6 to 12 months. So this is the only case that we do that. How about when we give immunoglobulin only and no vaccine? No vaccine is when we have an immunocompromised or a pregnant or a 0 to 6 months infant. This is when we give immunoglobulins only and will not give vaccine. Remember that I think the MMR is a live vaccine, and that's why we don't give it to pregnant or immunocompromised patients. Now, the only way we can give vaccine only within 72 hours of exposure is more than 12 months of age. Okay, if the child is more than 12 months of age. Okay, so that's been measles. Very easy. Now let's talk about varicella. Varicella here said that susceptible children and household contacts, the VZIG, that is also stored immunoglobulin, and the vaccine, we give them. So we give both. The second thing that says the susceptible pregnant women, newborns whose mothers had chickenpox within 5 days before delivery to 48 hours after delivery, will give the IG, or the immunoglobulin. Okay. So we have two cases here. We either give the immunoglobulin plus the vaccine, or we just give the immunoglobulins here. If we have any susceptible children or household contacts in general, we give the immunoglobulin plus the vaccine. If we have a pregnant woman, or if we have newborns whose mothers had chickenpox within 5 days before delivery to 48 hours after delivery, so we have 5 days before and 2 days after, so that's like 7-day period here, we give the immunoglobulin. So again, pregnant women, newborns who had their mother had chickenpox 5 days before delivery, 2 days after delivery, we give the immunoglobulin only. We do not give the vaccine. Okay, so that's been measles and varicella. How about hepatitis here? Well, hepatitis, we're going to talk about B first. Hepatitis B, we give the immunoglobulin plus the vaccine. This is given at birth, 1 month and 6 months of age. Well, in general, we give the vaccine, but we just give the immunoglobulin for exposure, especially if it is hepatitis B in the mother, and it can be transmitted to the child. 80% of cases they do transmit it, so it's important to give the immunoglobulin plus the vaccine at birth, and then 1 month, and then at 6 months. Again, immunoglobulin plus vaccine at birth, 1 month and 6 months. And it's going to be different because we give in hepatitis, we give the first dose in the first at birth, and then 1 to 2 months we give the second dose, and then 6 months to 18 months we give the third dose. But in general, we give it at birth, 1 month, and then 6. But we only give the vaccine. So the difference here is that we're going to give immunoglobulin as well as the vaccine. All right. Finally, here we have mumps and rubella, the rest of the MMR vaccine. It says here no post-exposure protection is available. So this is really important. The MMR vaccine in general is available, but measles is the only one that has something that would that is considered post-exposure protection. Mumps and rubella do not have post-exposure protection here. Okay, so that's the first table. The second table here, it says specific routine vaccinations, and the first one is hepatitis B again. Oh, I'm sorry. Before we actually leave that table, I missed a part here on hepatitis, and it had to do with hepatitis A. It says hepatitis A that if the child is more than 2 years only, immunoglobulin plus the vaccine. So more than 2 years only, immunoglobulin plus the vaccine. I'm very sorry that I missed that, but I got it now. So now the second, let's talk about the specific routine vaccinations. Okay, hepatitis B again, and it said here if the mother is hepatitis B surface antigen negative. Okay, so the first dose is going to be at birth, and then a total of 3 doses by 18 months, just like anybody else. And if the mother is hepatitis B surface antigen positive here, so that's different. We said the hepatitis B surface antigen negative before. If it's positive, we will the first dose of hepatitis B vaccine plus hepatitis B immunoglobulin at 2 different sites within 12 hours of birth. A total of 3 doses by 6 months. Okay, so that's going to be different from the 18 months part. So we give the hepatitis B for 3 doses in general, 18 months if the mother is negative, and if the mother is positive, we give it the 6 months period only. A total of 3 doses of the hepatitis B plus the immunoglobulin, just like we said before, actually. So, all right. How about the DTaP or the TBT or something like that? But we have here a total of 5 doses that we give. This is recommended before school entry. The last dose age is 4 to 6 years. We have a pertussis booster vaccine. It's also given during adolescence, regardless of immunization, if he's immunized or not. The TD is given at 11 to 12 years, then every 10 years. Okay, all right. Let's review that again. So DTaP, we have total of 5 doses just in general, is recommended before school entry, and the last dose is going to be 4 to 6 years of age. Then we have a pertussis. Let's just talk about P part here. The pertussis booster vaccine is given during adolescence, regardless of immunization. And finally, the TD is given at 11 to 12 years, then every 10 years. Okay, so that's been hepatitis B and DTaP. The Haemophilus influenza vaccine, conjugated vaccine here, this does not cover non-typable Haemophilus. So this part is just cover the most common one, which is B, and we do not cover the non-typable Haemophilus. This is not given after the age of 5. And invasive disease does not confirm immunity. Patients still require vaccines if they are less than 5. So even if he got Haemophilus influenza, he should get the vaccine, okay? because you could have other types, so you should really cover everything. But before the age of 5, that's the golden age here. Okay, how about varicella? We talked about varicella when I had to do exposure, but how about in routine vaccine? Well, this has been associated with the development of herpes zoster after immunization, so we should know about that. And finally, the meningococcal conjugated vaccine. This is given at the age of 12 years, or 11 to 12 years, or at the age of 15. So 11 to 12 years. Remember that 11 to 12 years for the TD booster dose, and we talked about that before. As a reminder here, that in the meningococcal conjugate vaccine, we give it at the age of 11 to 12 or at age 15. This is indicated for all college freshmen living in dormitories, and Minumune, the MPSV4. This is indicated in children age 2 to 10. I don't really know what the Minumune is. It's probably the meningococcal something, I don't know, vaccine for, indicated in the children age 2 to 10 years. I don't know what's the difference here between those two, the meningococcal conjugate vaccine and the Minumune. If somebody knows that, please can you comment below and let me know what the difference is exactly. It says here in the general table, the meningococcal hepmin something, I don't know. It doesn't really specify that there are two different vaccines here. So I assume that there is only one type of vaccine, but the meningococcal conjugate vaccine, it seems different than the Minumune one. So, okay. Regardless, let me know in the comments below if you do know this piece of information. All right. Okay, so that's been the vaccinations. We just to recap, we did some tips in the and some common errors in the exam that we might find. We talked about the active immunizations after exposure and what to do with it, and the specific routine vaccinations. We covered the specific parts that had to do with specific diseases like hepatitis B, varicella, and the meningococcal conjugate vaccine. The next page is going to be child abuse. It's only one page, and I believe we can cover it, and then we're going to go on with the respiratory disease later on. So child abuse here, it has something kind of like the note on the side, and it says in the note, do not forget dilated eye exam by an ophthalmologist in case of suspected infant abuse. Okay, let's see how would that go. In the diagnostic testing in child abuse, if you suspect child abuse, we're going to do first the laboratory studies, and that's going to be PT, PTT, platelets, bleeding time, and CBC. I'm assuming this has to do if we see bruising, so we can actually diagnose that the bruising had to do with child abuse instead of something else. It doesn't really say that here, but it's just my assumption. The second one is going to be skeletal survey and see if there is any broken bones, history of broken bones, if we can see multiple broken bones as well. In the third one, if severe injuries, even with no neurological signs, we should perform a head CT scan, plus or minus MRI, if we need it, and ophthalmologic examination. And that to do with the dilated eye exam. The fourth thing that we need to do, if there is an abdominal trauma, we should perform a urine and stool for blood, and that would indicate if there is an injury to the kidneys or the bowels, liver and pancreatic enzymes, again for the same cause, and an abdominal CT scan, so we can see if there is an inner injury or fluid collection and so on. Finally, we should do a urine toxicology screen, especially in the case described altered mental status. That could be a type of abuse as well. Okay, so what we're going to do again, just to recap, laboratory studies, PT, PTT, platelet, bleeding time, CBC, skeletal surveys, and if there is a severe injury, even there is no neurological signs, we should do a head CT scan, plus or minus MRI, ophthalmologic examination. Abdominal trauma, we're going to do urine and stool for blood, liver and pancreatic enzymes, and abdominal CT scan. Urine toxicology screen, especially if there is an altered mental status. Okay, how are we going to treat that? The first step is always to address the medical and or the surgical issues, of course. Then we can report any child suspected of abuse or neglect to the child protection services. This is really important. Initial action, I guarantee there's going to be a question about child abuse in the exam. I don't know why, I just feel it because in step one, that was a really big thing to actually just call the Child Protective Services in behavioral science. I think they really cared that you would understand that part and know it. So if you do know it, that's just one question in the bag here. Okay, so the initial action includes a phone report. In most states, a written report is then required within 48 hours. So just call and then write the report. The following are indications for hospitalization. So when can we hospitalize or should hospitalize a child abuse case? First, if the medical condition, of course, requires, this is a given. If the diagnosis is still unclear, we're not really sure, so we should hospitalize the patient and monitor. This is for two reasons, I think. If we can diagnose him better, or just do the laboratory studies and everything while we see that patient. And the second, if there's a child abuse case, we can protect that patient. Finally, there is no alternative safe place. Okay. So, if parents refuse hospitalization or treatment, the physician must get an emergency court order. So, this is another situation where behavioral science would come in, and it's straightforward. If they refuse, get a court order. Okay. The final paragraph here says that you must explain to the parent why an inflict injury is suspected abuse, that you are legally obligated to report it. So you're not going to hide it. You're not going to just do things behind their back. You're going to call the child services anyway, but you have to explain to the parent why an inflicted injury is suspected as abuse, and that you have made a referral to protect the child, and that the child protective services worker and law enforcement officer will be involved. So you should really explain. You shouldn't really hide your actions or do anything behind their back. So that's been child abuse and immunizations. It's been 22 minutes. I think we're gonna stop for just a quick 5-minute break, and then we can be back fresh in respiratory disease. I don't want to start and then just and stop right away after the 25 minutes are over. So I'm gonna take a quick break, 5 minutes, and then we can be back. I'll see you in the next one. All right, bye bye.